something you've changed your mind on?
So in no particular order, other than the order that I listed these things out, the use of metformin in very healthy individuals is something I've changed my mind on. So I don't think we talked about this on any of our other podcasts.
I don't think so. So yeah, what was the previous position or conclusion, and then?
So my 2010 view, which sharpened and became more and more bullish from, say, 2010 through 2015, 16, was that metformin was a very, very low-risk cancer-mitigating drug in anybody. Now, I believed that it was more so in patients who had diabetes or conditions that approximated diabetes, like hyperinsulinemia. But the data were, I think, quite convincing to me, and my extrapolation was, well, even in people who don't have diabetes, this is still a great longevity agent.
And for those who don't know, what does metformin do?
Well, that's
I guess a big question.
Yeah, and that's part of the rub is metformin does a lot of things. It's a mild mitochondrial toxin, and this becomes relevant to the story. So it sort of inhibits the first complex of the mitochondria, what's called complex 1. And by doing so, and it seems to do so preferentially in the liver, it leads to a cascade of events that activates an enzyme called AMP kinase. And when you do that, the body basically starts acting like it's in a fasted state. So it's sort of like a junior fast in a pill. And for people with diabetes, what's beneficial about it is it lowers the amount of glucose that the liver puts into circulation. So there's plenty of benefit to that, and there's no disputing its efficacy there. And in the last 5 years, frankly, it's become a very popular topic. And I've interviewed a guy named Nir Barzilai on my podcast, and we've talked exclusively about this. Nir is one of the world's experts on metformin. And he's leading the charge to do a very large clinical trial to test the question of whether metformin is a longevity drug in non-diabetics. Anyway, the point is, my baseline view was that this is the case, and I had been taking metformin since 2010. What changed a year ago was I began doing a very focused type of exercise that was geared towards mitochondrial performance and efficiency, something called Zone 2 training, where you basically push the boundaries of how much work you can do while keeping lactate below 2 millimolar. So lactate is a byproduct of metabolism under conditions in which you're asking the body to make ATP, which is the energy currency, at a rate faster than can be sustained aerobically using oxygen only. So by pushing the boundaries of how much work you can do, and I mean work in the very technical sense, so how fast you could run, how many watts you could push on a bike, and ratcheting up that level while still keeping lactate below 2, you're training your mitochondria to become more and more efficient. And what I started noticing when I was mucking around with different drugs was whenever you have metformin in your system, that output goes down. So, and again, when you thought about it for a minute, that shouldn't be surprising. It's a mitochondrial toxin.
Could you don't lose your train of thought, but what are mitochondria? So fucking fascinating. But mitochondria are, I think, really, really interesting. I don't want to take us off the rails.
Yeah, they do a lot of things, but for the purpose of this discussion, what they do is they do the most efficient form of energy transfer, which is transferring energy that comes in the chemical form of energy, like food energy, right? So when you eat something like glucose or fat, or your body breaks down and gives you glucose and fat, how do you turn the energy that is stored within those chemical bonds, the carbon-carbon bond, the carbon-hydrogen bond, et cetera, how do you turn that into ATP? And you do that by first breaking those things down and getting electrons into these electron donors. And people who might remember from a high school class, something called the electron transport chain, that runs through the mitochondria, and those electron donors eventually donate back, make an energy gradient that makes ATP, and in the end, all they spit out is carbon dioxide and water. So that's why we breathe out carbon dioxide and water vapor in exchange for taking food and making energy. So they play an essential role, obviously, in energy production. And if you lose the ability to make energy with the mitochondria, that's effectively what happens to a cancer cell. So this idea of zone 2 efficiency is so important for metabolic health that I started questioning, well, why the hell would metformin be a good thing if it's impairing that? And basically, after doing a lot of experimenting with and without metformin under different clearance pathways, et cetera, it became unambiguous to me that metformin was impairing this, and there was no two ways about it. And then I began to question, well, how would you reconcile that with the fact that metformin is helpful? And then you realize, well, metformin's only really ever been shown to be helpful in people who have diabetes. And when you look at the sort of mitochondrial performance of people with diabetes, it's abysmal. In fact, even though that's not a hallmark that the medical system would typically pay much attention to, but if you do that type of zone 2 testing in people with diabetes, it's such a contrast between them and someone without diabetes. So I realized, well, maybe when your mitochondria are that sick, a little bit more toxicity doesn't matter that much. But if you're playing a different game, it might. Now, since that time, a number of other studies have come out. I've written about one of them, maybe actually two of them, that look at the effect of metformin and mitochondrial inhibition on the difficulty of growing muscle mass, which again is not as interesting to me, but that appears to be a totally different issue, which is the blocking of sort of the stress response. I think the jury's still out on all this.
Meaning that that metformin appears to inhibit versus not administration of metformin.
Correct.
Hypertrophy muscle growth.
That's right. Metformin seems to impair the sort of the inflammatory response that would be pro-growth to muscle, pro-adaptation, for lack of a better word. I think it's still too soon to say how this story shakes out, but I was basically in the past year, I've seen enough data to suggest that for me personally, the benefits of just focusing and doubling down on my exercise are probably going to yield better results than the use of metformin. And of course, then the question is, how do you translate that into patients, and where do you draw that line? Which patients are sufficiently on the healthy enough side? And I don't know the answer. I think my thinking on that is the more you exercise and the healthier you are, the less benefit and potentially the more detriment you could experience from metformin.
I mean, I suppose this is not Tim playing a doctor on the internet, but just thinking about that even if someone were, say, pre-diabetic or presenting the symptoms of or biomarkers of someone who's pre-diabetic, it might make sense to try other interventions before metformin, right? Because you might slap on 10 pounds of muscle mass and lo and behold, they're much better at disposing of glucose, or any number of things could change.
I think no matter what, like if you take somebody who's got diabetes, I don't think people appreciate how potent a tool fasting, exercise, and sleep are. When you rob someone of sleep, when their sleep sucks, when they're not exercising, and when they have full stores of glycogen in liver and muscles, which is basically the state you're in when you're constantly fed, the ability to reverse those three things is more powerful than all drugs combined. I mean, so I agree. If there's a way that you can treat patients without using medication, one should always do it. Sometimes metformin does offer a great step forward. And again, it comes down to every patient's ability to sort of adhere to exercise and all these other things.
Would you ever consider using metformin? Maybe this is more a job for Acrobos. Is that?
Mm-hmm, yeah, you remember that.
But using, say, metformin selectively when you're going through a period of overfeeding for some purpose.
I mean, I think those are exactly the kind of questions I'm still struggling with, which is, does it make sense to cycle metformin? Does it make sense to only use metformin in the evening but not use it in the morning? So let's say in the morning, you exercise, but in the evening when most people are fed, like for one of the things I did notice when I stopped taking metformin is definitely my nighttime glucose levels are just a little bit higher, because nighttime glucose is controlled by the liver. It's not really a function of what you just ate. it's you're so far outside of that last meal that it's generally the response of the liver putting glucose in circulation and titrating that. So yeah, I think there are probably different, like, 5 different ways that you could sort of slice this thing up and decide on how to do it. And I don't know the answer, and I guess I reserve the right to change my mind again. But for now, that's been a pretty big change for me.